Get started. Okay. So good evening and welcome to the Healthcare is a Racial Justice Issue 4-part series, which is organized by Michael Bayer, who works for the Coalition of Chicago Catholic Churches, and myself, Jessica Simpson, the president and founder of the White Coats for Black Lives chapter at Loyola University Chicago Stritch School of Medicine. I'm also a second-year medical student at Stritch, and I'm incredibly thankful for this opportunity to engage in meaningful conversation with our panelists and with all of you. So tonight is the first session of the series that will take place throughout the month of October. Our focus tonight is to discuss racial justice, specifically training healthcare workers to provide equally compassionate, patient-centered medical care. I will ask our panelists questions, and you all will have an opportunity to also ask your questions via the Q&A chat. Due to the time constraints, we may not address all of your questions, but we hope that your questions will be addressed throughout the 4-part series. We ask that everyone be respectful, and this is a safe space, and we encourage you to ask your questions, any questions that you have, okay? So without further ado, I'm going to introduce our speakers for tonight. Dr. Lena Hatchett is an associate professor, at Loyola University Chicago. She's the co-founder and principal investigator for Provisio Partners for Health. She also is nationally recognized as a community coalition organizer, and she invests in community assets to generate health and economic growth. Dr. Hatchett is a graduate of the State University of New York at SUNY Brook with a PhD in social and health psychology. And she is a public health expert that has a lot of experience working with the local community, including Trinity Health Systems, as well as the Cook County Department of Public Health. Dr. David Ansell is the Michael E. Kelly Presidential Professor of Internal Medicine and Senior Vice President and Associate Provost for Community Health Equity at Rush University Medical Center in Chicago. He too is a graduate of State University of New York Upstate Medical University. He did his medical training at Cook County Hospital in Chicago, and he spent 13 years at Cook County as an attending physician and ultimately was appointed chief of the Division of General Internal Medicine at Cook County Hospital. He has research experience and is also a public health advocate and a physician advocate, and he focuses on eliminating health inequities. So tonight, the first question is directed at Dr. Ansell. Dr. Ansell, you wrote a book entitled The Death Gap: How Inequality Kills, and you discussed the implications of inequality of life expectancy in Chicago. How does one's zip code determine when they will die, and how does socioeconomic status predicts health outcomes and premature death rates?
Well, good evening, everyone, and thank you for organizing such a really important program. We need to be having these kind of dialogues. I discovered, I trained in medicine, and much of my training was probably similar to how it is today, and on the biological determinants of health. I understood sort of vaguely that being poor wasn't good for your health, but I didn't really understand how it really worked. I came to Chicago, and as you noted, trained and then stayed at Cook County Hospital for 17 years. And I understood that, while I was largely seeing poor people and they had bad health outcomes, I hadn't actually dived into the numbers. And then when I moved to Mount Sinai in the 1990s, we began to do work on looking at causes of death by neighborhood in Chicago. And we actually did a very interesting study, because we know the causes of death from the health department, but we didn't know what diseases people had. So there was a 5-neighborhood door-to-door study in which we knocked on doors. We had a community advisory committee that told us, don't ask about drugs and alcohol, but ask us about depression and ask us about stress. and ask us about racism. And what we found is when you took, so the 5 neighborhoods, one was a white middle-class neighborhood in Chicago, and the rest were either Black or brown neighborhoods, Mexican, Puerto Rican, and Black neighborhoods. And what we found not only shocking mortality gaps, but shocking disease incident gaps by neighborhood that cannot be explained by what I call the 3 Bs: beliefs, behaviors, and biology. And it really went against everything that I learned in medical school about causation. And when you sort of ask yourself what's causing these differences, the conclusions that we came to was that it was structural in nature. So we hear about the social determinants of health. I don't like that word. They're non-descriptive. There are social needs. There are structural determinants of health, things like structural racism. There are things like capitalism and exploitation that cause poor health. But ultimately, it's the lack of access to power, resources, and money in neighborhoods that determine who dies earlier. And the unique way that racism plays into this is by concentrating poverty into Black and brown neighborhoods. So for example, 30% of Chicago Black population is poor, and they live in concentrated disadvantage or poverty. 10% of Chicago's white population is poor, but there's not one poor Chicago neighborhood. So where you live dictates when you die, and it requires us as healthcare workers to think about addressing root causes versus just the diseases.
Right. And so what is the root cause of these inequalities?
Well, that's a great question. And I think from everything we know from the literature is that I call it economic exploitation. So when people work and yet are poor and can't make a certain income, they can't actually have leisure time. They live in substandard housing. They don't have access to education. Those things are acts of oppression that actually deplete life. And there's a whole set of biological mechanisms by which that happens. But in the United States, we've seen over time, those who are in the lowest quintile of income, life expectancy has actually dropped, while those in the highest quintile in the United States, the life expectancy has risen, and therefore the gap has gotten better. It's gotten bigger. But I name racism has to be named because the contours of Black poverty and white poverty are different for the reasons I said, because of segregation, and that have conditioned, it created conditions that dictate that Black people actually of all socioeconomic status die earlier than white people.
Wow. So Dr. Ansell just laid out a lot of information there. And Dr. Hatchett, I know that you have a lot of experience in research with really diving into more of the interpersonal issues that are related to what Dr. Ansell was just talking about. I think it's important for us to break that down. So can you just help us understand more about identity? Because he also talked about, Black and white power, those sorts of things. Identity influences someone's health, correct? And their overall health and well-being. But how do you define whiteness or white identity? And how is it connected to Blackness or Black identity?
Thank you so much for having me and having this opportunity to share. Whiteness and white identity is something that I'm exploring to understand solutions towards racism. And I agree with what Dr. Ansell is saying about segregated, concentrated poverty for Black people. And we know we are serving BIPOC populations, but we also live in a culture with a history and a society of anti-Black racism. So those neighborhoods and those zip codes shift and change based on the percentages of Black populations that live there. So once a community or a neighborhood starts to increase the number of Black populations, that starts to be a place that people want to disinvest in and not go. The same with Black schools, the same with Black businesses. And that is part of how we think as a culture to have this hierarchy, and there's a new book out on a caste system. So when that comes to identity, and I want to go slow right here, the way we judge and categorize our world and the meanings behind things, we have the expectation that Black is bad, anti-Black racism, and white is good. And what I'm looking at is seeing Black and whiteness on a continuum. I'm pretty light-skinned for an African-American woman. That gives me an unearned system of advantage in American society. Intentionally or unintentionally, I am getting an unearned privilege from the color of my skin. And if you can accept and agree that I have an advantage as a light-skinned person, a white person has that unearned privilege and value, the standards of beauty. Just because you're white and you've created something, it is deemed more valuable in our society. And now, if we think about this on a continuum of what it means to be white and what it means to be Black, we think obsessively about difference and disparities. So the minute you name something, I talk a lot about food. We work in the food justice system. When we all want to eat healthy, and when white communities start eating spinach, it's a good thing. But if Black and low-income people start having access to more spinach, white communities then have to differentiate themselves and their value. They start eating kale. And we continually perpetuate this difference of what it means for whiteness. And we're exploring it now, we're understanding. I think some general population wouldn't necessarily recognize whiteness as a race. And that white normativity is a big part of the challenge. But we keep reproducing it. Once we've said if something's white, then Black must be different. If white is good, then the Black alternative must be bad. And we do it consciously and unconsciously. So luckily there's work on white normativity and understanding that privilege. And that's some of the work that we're looking at in terms of a change and a pathway out of this repetitive behavior. And we can't not understand that this is our culture. So right. We can adopt these assumptions, whether we're white or Black, right? I mean, right. Straighter hair, straighter noses, lighter skin, all of those things come with conscious and unconscious judgment of what's good and what's bad. And anti-Black racism means that anything Black is going to be devalued, stigmatized, including our communities and including the people. Let me.
Right, and that is, yeah, that is. Thank you so much for explaining that, because I think also sometimes we're not always aware of how we are all influenced by these social constructs and how they impact, different decisions, and how we're so closely tied to race and Blackness and white as a part of our identity, and then how that also influences our experiences that we have as people. So my follow-up question to you, Dr. Hatchett, or Lena, if it's is that, because I know you prefer for me to call you Lena, is that
call me David.
Right, I know. Next I will, for sure. But if you could just please share some of your patient-provider relationships that you've researched throughout the years, where this is important and how it has implications for Black, Indigenous people of color, and if you've noticed any shifts in that change, because we have people who are nursing students, medical students, practicing physicians who are on this call and people who will be, who will probably be interfacing with the healthcare profession, who identify as Black, Indigenous, people of color. And so I think it's important to talk about those experiences because there is some connection to their experience and their health outcomes.
Yeah, that's a big question, and I'm going to try to answer it from my personal journey in understanding this. And a lot of what I'm going to talk about, I actually learned with medical students. And when I came to Chicago, just before that time, I was working in Malawi and in a totally different culture with different challenges around HIV prevention. I had a lot to learn about Chicago and what I was going to do. And I'd always been interested in the issue of structural racism because to me it felt like my life depended on it, and the injustice was so wrong that I was in a position to have power and privilege to actually change it. And the further along I went in my studies and my research, the less easy it was to talk about racism. You'd get dinged, or you were questioned, or you were judged, or is there really racism and how does it work? And there were different code words to talk about it. So I was really struggling personally to work on structural racism in the way I understood. My undergraduate degree is in Black Studies and Psychology, really struggling because I thought, well, I'd have more knowledge in my PhD program to have more influence. But yet I was being silenced professionally because of scientific racism. So starting from that place, and David was one of the leaders, the social justice leaders that I got to hear and speak when I arrived in Chicago, to help me find a way that I could keep an academic career and do the work that was meaningful to my soul. That you could be a voice and you could push forward, you could study these things and make an impact. So I had to give you that background of the struggle of trying to understand. When I latched onto the concept of cultural competency. It was vogue at the time, and people were writing about it. And it's the settling and the silencing that we do. In my heart, around my kitchen table, we talk about racism every single day. When my husband was getting pulled over every night on his way home from work. So structural racism was real, but I couldn't talk about it in the academic circles that I was sitting in a real tangible way. And trying to bridge that divide, I turned to the medical students to look at what we could do. And I held on to cultural competency because that was popular, but it was always such an empty feeling. It's a good concept, it's right, but it was missing the power dynamics and the real stories behind why we have different cultures because of segregation. And I like to think about psychological oppression as a phenomenon that we're living under. And that shift, that understanding that because we don't have the right root cause and the intent, that we're not looking at power, not looking at oppression, and we're not looking at it as a societal economic factor, we keep missing the solutions, right? So cultural competency ended up just stereotyping communities more and generalizing more, and allowing medical students to feel like, well, I've had a cultural competency course, so I know what's needed. So long story short, working with medical students at Loyola, we started to look at cultural consciousness. And it starts with you. So rather than being a provider working with a Black patient and thinking about what do I know about that patient or what does that patient need, you need to reflect on who you are being in the relationship. Are you being the expert? Because if you are, then the patient ends up being the naive layman. If you're being the savior, then the patient ends up being the victim waiting to be saved. And if you can focus on who you're being and your identity in that moment in a real honest way, you're going to have a better relationship because you're allowing yourself to ask, who is the person in front of me? And doctors know a lot about medicine and disease, but the patient is the expert of their own lives. And we seem to forget that when it comes to Black people and people with low income, right? We think that we know better than them. So I hope I'm not taking up too much time, but cultural consciousness is understanding and starting with yourself. Recognize, are you bringing power into the relationship? Is it more important for you to look like you know something than actually ask so you can understand and build rapport with patients? And that's something I learned while working with the medical students.
Right, right. I think that's really important because as a medical student, we don't really talk about what you discussed as far as approaching the patient as just another person. We always we're kind of coming from this authoritative position. And I think what you describe is more related to patient-centered medicine, where we're focusing more on how we can interact with the patient. And we have a few good questions in the chat that I want to bring up. And so there's a particular question from a nurse, and I think it again kind of it goes into more about what I just asked you. But as a white ally of people of color and a nursing student, how can she do more to help the Black community? She specifically asked about the Black Lives Matter protesters, and I think also as a future nurse, what can she do? And I'm wondering, Dr. Ansell, too, since you are a practicing physician, if you have any thoughts on this, and you identify as a white male, and you might have seen some of these interactions where where some of the providers are approaching it from an authoritative position, or they're focusing more on their identity, and therefore they have preconceived notions. So, do you have any advice about what we can do, especially for allies, to support people of color?
Yes, let me try this. I'm notoriously bad at answering the question. I'm thinking about what Lena said, and you call me Dr. Ansell. And
oh, I'm sorry. I meant to say David.
You got to keep it all like, but I want to go back to this idea of identity. So white identity. So, and I think this is a critically important piece to, and it took me many, many years. I don't think I was until my mid 50s until I felt comfortable myself in seeing how white supremacism permeated all of our institutions, including my own at Rush, that there are spaces that are white spaces that most white people don't notice as white spaces. And so whiteness is often held unconsciously, but it's consciously applied. And so this idea of reflecting and self-consciousness about whiteness and the unearned advantage in that one has is a matter of consciousness, and then speaking about it. I think as a white man, I for many years of my career, even though you could say I was fairly socially aware, I viewed the problem as being one of economics only and poverty until I began to see how toxic, how that racism in fact was a toxic form of oppression that had biological outcomes. And so naming that becomes critically important. And so understanding that medicine and nursing were in this country have all been built on a foundation of white supremacism, and many of those vestiges exist in our policies and practices. Take, the scientific racism of biological measurement, right, of EGFR or heart disease risk, or even the kinds of things that people learn in nursing school, in nursing texts about how some people feel pain and others don't, all of that stuff is, I think one has to approach that relationship with a patient with a high degree of consciousness about the power you're bringing into that room, and come in and approach it with a high degree of humility and inquiry. And so oftentimes, and I'll tell you in medicine, I think nursing is a much more holistic field. We are asked we ask people about their chief complaint. We have to assume that everything that we do has been imbued with supremacism. And the deconstructing starts with even how do you take a history. And so, versus what's the matter, I think you turn the lens and try to understand first what matters to you. Who are you? Tell me about your family. Tell me, it's a little bit of breaking down that barrier in a very, very conscious way. I mean, I think we need to redo the whole history and physical taking. I really do. I think it's totally backwards, and it sort of replicates the power, that power structure. So as an ally, so one is to be a real ally, we have to learn to speak in the moment about how racism and other forms of oppression, remember these are acts of affliction with biological consequences, are working in the moment. And they're occurring because we all have the collective mental maps in our institutions that perpetuate these historic injustices. And only when white allies in the moment can learn to speak and say, well, hold on a second, I'm not sure she really understood the discharge instructions. And, getting into that momentary thing and disrupting the system, that's the best way to allyship. But also speaking to it and naming it. Lena mentioned about how she got to a place where you couldn't say it anymore. Well, it's up to white allies to say it. I just think that comes as simple as that. So my family was wiped out in the Holocaust, and no one would have thought it was up to the Jews of Europe to speak up on their own behalf. Someone else had to do it. Or the Me Too movement. It's not up to women to speak up on behalf of sexual predation. It's up to white people and those who've been assigned to advantage to speak.
Yeah, I think that's a very different approach to thinking about your role as a physician, that maybe really as physicians, it's our responsibility to be the ones that are speaking up and not always waiting for, our patients or vulnerable populations to do that.
But also,
there's another
one other thing, to ask your patient, what has been your experience?
Definitely. I think also that's a really good question. And so I have a public health background, and I always think that it's important to ask, what happened in your childhood? What happened as you were growing up that influenced the way that in which you live your life now, and about like who you are now? Because we're talking about, like you said, systemic racism and structures. And so, and actually that there's someone who asked a really good question. I have other questions, but I do want to ask some of the questions that are in from our people who are participating with us. So one person said, value-based healthcare emerged to improve quality while containing costs, right? However, it impacts racial health disparities. However, its impact on racial health disparities has been limited, which we've known actually hasn't really, there really hasn't been a decrease in health disparities. Black, Indigenous people of color and are more likely than white patients to receive care at under-resourced hospitals. Many of these points of quality are not in the zip code, right? But they may be principles grounded in an anti-racist, just-oriented framework. How can we explicitly incentivize disparity reduction?
Maybe I'll start, and Lena, you can jump in. So there's this notion of racial capitalism. So I think capitalism is our economic system that does one thing really well. It concentrates capital into the hands of the few and at the expense of other humans. And because we live in a racialized society, going back 500 years, where we devalued people of color, Indigenous people, and the values assigned to them have been different. The way that we've organized our whole healthcare system is through racialized capitalism. It played out in front of our eyes during COVID, right in front of our eyes. And in the following ways is that safety net hospitals swamped with patients and not having the resources because they rely on capitalism, free market system. They were bidding for PPE and masks with different states and things like that. St. Anthony's on the southwest side of the city started making its own hand sanitizer. It's the way we devalue people's lives. This idea of value-based care, I want to say, gag me. It's people-centered care. So in my version of the world, we have to remove profit taking out of healthcare. The only one who made money during COVID were the insurance companies and the pharma companies. So we have actually a system that's a reinforcing racial capitalist system in which Black people and brown people in these neighborhoods of concentrated disadvantage either do not have health resources, have substandard resources, or undercapitalized resources. And profit is not possible. So we need to really fight, I think, for a single payer Medicare for all system. It doesn't solve the problems of structural racism, but it certainly in countries where they have it in place, reduces death gaps. So I think it's a political, we talk about social determinants of health, structural determinants of health, they're political and economic determinants of health, and they're directly intersect with white supremacy. And Lena, take it from there.
Yeah, thank you for getting us started. And we have a lot of half-baked solutions and ideas that are running around, and not to judge them, because we medicalize everything. So we think, okay, there's a problem there, let's find the quick fix and let's find the pill. But we are dealing with a systemic issue, as David has said, and so we need systemic solutions. So you got to look at the root cause, and we don't value people, we value money and wealth and the economy. And so we're always selling out. If people can't be a consumer and purchase something, then they become the commodity that we sell. And you have to look at those questions where you're working within your system. How are we really treating people, and how are we treating ourselves? I want to jump back to the person who asked that she's going into nursing school and she wants to help. And I think people who would have come to this call tonight are people who truly want to help. And that's been a myth that middle-class communities and people with education have been telling us ourselves that we are here to help. And I use myself as an example. I really thought that I was here to help communities that had less, particularly people with less education. I had worked hard to get my PhD. I'm the first in my family to go to college. So I thought for sure, I'm all about helping. But was that the truth? And we stopped looking at, no, I was there to help myself, to have this degree, to have an income, to have the kind of quality of life, a middle-class quality of life. And that came first, and helping people was really second. And if you don't ask yourself the truth, you actually do not help. And we have the luxury, just like white privilege, as a PhD academic, I have the privilege of never asking myself how important my income is and how much I earn and and the value of my lifestyle. But that's why I'm here too. And I can have both. I can help and acknowledge the privilege and the power I have from my degree and use it for good without only assuming I'm here to help somebody else. And that honesty helps you make good decisions. That honesty and authenticity helps you to have the right kind of relationships. And I think from your question, the real kind of solutions you want to be impactful for underserved communities as an ally and as an honest broker, and not one that, it's a myth that we tell ourselves in the middle class that, we're really just committed to help. Well, it's a whole lot easier to help when you have resources, power, and privilege.
Right. And
yeah.
Oh, I was just going to say, and that might be also tied to their identity, right? Like our identity of being that person who is the savior. And so both of you both talked about like being more in tune with yourself, and being aware and conscious in the moment in which you're moving about this space. There's another really interesting question that I think I'm also interested to know your thoughts on this, but why do you think that poor white people continue to support an oppressive system that also keeps them down? You know, why do you think that is? Do you think that they're not aware of the system? Do you think that this also has to deal with their identity, like we were talking about before, of their whiteness? What do you think it is? I'm gonna, yeah.
Go ahead.
Thank you.
Jefferson.
Thank you, Lena. I was gonna direct at you first because I think
yeah. I'm gonna give the short version because it's a lot of our identity, and it comes back to our culture and our capitalism, right? We feel like we have independence and choice and control, but we don't. From a social psychological standpoint, we are being fed 24/7 what we should think, what we should believe, what we should buy, and who we are. And so poor people, we don't acknowledge poverty, so they are stigmatized and discriminated and blamed for what they have and don't have, and their lifestyle is judged, especially in healthcare, just based on your income level. It doesn't matter what you're doing. If you're poor and doing it, it's wrong. And so there's a desperation, a sense of belonging that we all have, no matter what class, culture, race, ethnicity we come from. We want a sense of belonging. And in American society, to belong in the middle class is a value. And then if you're middle class, then you need to belong in a higher level class and have more money and more things. And they're fed that 24/7. So it's very difficult for people to actually have their own identity and their own value system just naturally, right? When you're seeing it in a different message. And the stigma of being poor is immense. And the privilege, going back to that honor and privilege, the privilege you get by playing middle class. And we had a longer time, David and I could talk about, take race right off the table and talk about class and income and that systemic structure. But that's feeding into us and we're unconscious about it. So I think it's very natural for someone in low income to fight or advocate against their own needs because the rest of society is blaming them for what they don't have and their lifestyle. And wanting out is a part of our culture. And I think through this movement, we're getting a chance to be independent and think for ourselves and create our own values that might be different. And we can do that together, regardless of race. One of the messages I want to say tonight is we're in this all together. When we segregate those 5 zip codes that David was talking about and did that immense research, that means white middle class people are segregating themselves too. They don't have the freedom to go wherever they want to, whenever they want to. They're segregating themselves too. And we're all suffering from structural racism, but some of us aren't aware of it.
Yeah, just to take what Lena said in that question implies, first of all, we have multiple identities, but because whiteness as an identity, as I say, is unconsciously held, but consciously, but applied and noted, it gives poor whites sort of that sort of leg up in a sense. What we know about the economics of this country is there is not the narrative of upward mobility is a false narrative. And I refer you to economist Raj Chetty, who is, you should look at his YouTube, RAJCHETTY, and it's tremendous. And it's true if you're white or you're black in this country. And so the narrative in this country, and it's because of capitalism, in the way that it actually works, that if you are poor in this country, whether you're white or black, in most places in this country, your children will be poor. It's worse for black people. So don't get me wrong. It's worse for black people, but white poor are more likely to have the poorer generations after them if they start off poor. The identity that people have, I'm Scotch-Irish, you know, my people are from Denmark, or it gives people something to hold on, and to deny sort of the reality of their situation and that allyship around economic justice that really crosses over all races, ethnicities, and particularly gender, women as well. But the other thing that it does, it's kept us because people have wanted to deny anything that looks like an entitlement to people of color, whether it be the ability to come to this country as an immigrant, or how Social Security and Medicare were set up to exclude Black and brown people. The idea of having an entitlement that someone else can get has been played politically to keep us from moving ahead as sort of for the common good. So I think again, this issue of racialized identities has kept us from coming together around our common set of needs and values.
Right. So David, as a physician and a medical school professor, what specific steps could medical schools, hospital systems, and individual healthcare providers take to address all of the things that we've just been discussing related to race and health outcomes? And who is really responsible for addressing these concerns? Who is responsible for making sure that patients are seen and heard, and what hasn't worked in the past where people were trying to address these issues, mainly health disparities, and basically what can we do now? I think it's important to talk about solutions too, and not just the problem.
Yes, there are a lot of things we can do and should do. So I talked about a political solution, and I talked about economic justice, which has political solutions to it. But let's talk about the medical school stuff right now.
Right.
So number one, at the turn of the 21st century, there was a couple reports from the Institute of Medicine. One, and important, was called Unequal Treatment. So that was one, and there was another one, Healthy People 2010, released in 2000, with the idea that we were going to eliminate health disparities in the United States by 2010. Ladies and gentlemen, that didn't happen. But what also didn't happen is we didn't collect data on patients by race, ethnicity, language, age, gender, sexual orientation, gender identification, to understand where we had gaps and what we needed to do. So that's the number one thing can do. Number two is medical school and nursing school curricula need to teach, many things, but need to teach about the social, structural determinants of health alongside with the biological pieces, but particularly talk about racism and other forms of oppression and their impact on health. We don't learn in medical school about allostatic forces, the effect of chronic stress, as Dr. Hatchett mentioned, as a driver. The idea that telomeres are shortened by exposure, biological weathering. There's a whole field out there, and that needs to be central to our work. But we've got to take it one step further. We have to, like I said, American medicine was founded on foundation of white supremacism, and many of those foundational pillars are still in place. And so when you look who's in leadership, who's in medical school, who's in hospital leadership, who's on the board, we have to cleanse our own houses first by applying racial justice principles in our own organization. I want to say this last piece because I think this is my deepest white man insight to this whole problem. So it's one thing, and it sort of came out before about why are some neighborhoods concentrated poor and concentrated people of color. And so there's overt racism and extremism that we can all sort of say, you know, we have to fight in the moment. Then there's unconscious bias, the work we have to do inside our own heads. But this is a perpetuating system of oppression that manifests itself in our policies, our procedures, and our norms. So when Black people move into a neighborhood, businesses move out. And then white people and other people don't go into those neighborhoods to buy. And when someone's hiring in an academic medical center, a hospital, they are going to, if the systems aren't in place, they are going to hire white people and often men into these positions. I'm not saying they're going to uniformly do it, but lip service to diversity and inclusion, but actually not taking on structural racism and institutional racism in the way that it works through policies. We can't dismantle racism without dismantling the policies in all of our institutions. And you know, if the leaders of these institutions can't, so how does an institutional leader lead an institution through this work if they themselves don't feel it or see it? So there's work at the leadership level in order for the organization. So that's a lot I said, but all of it can be done, and all of it should be done.
Yeah.
Thanks, David. And I'll just add to that, while it seems like a mammoth task, cultural changes and values have happened overnight with systems falling down and being rebuilt. Our culture is continually evolving, and when we make racial justice a cultural norm and value that people want, and it takes all of us, inside institutions and outside institutions and the voice of community, if we all start to see the value of this, it could really change. And if we think about we're all in this together, I teach majority white students, and I'm asking them, how is structural racism affecting your life in your institution? Don't do it for me, do it for yourself and what you value as a culture and as a society. And finding that actual win-win can turn people's attitudes, because they don't necessarily understand structural racism and how it impacts their own lives, and how as a country we're failing ourselves and we're not growing.
So
definitely. I think,
could I just add to that just for 1 second, because I think Dr. Hatchett said a tremendous point. One is, this is about all of us together. And I tell you, you know what, in the rapidity of change, so I'm going to give you marriage equality. In my lifetime, the attitudes around people of the same sex loving each other, or even transgender people's rights, have completely evolved and evolved pretty quickly. Some of the work that's happened in Chicago, because of the response of the institutions to COVID, but also the response to the lynching of, you know, Minneapolis, it was just so.
George Floyd.
Yep, and we all had to witness it while he narrated his own murder. 40 hospitals in Chicago signed on to a declaration. This is the first time, a declaration that a month before, I guarantee you, 40 hospitals and clinics signed on to a declaration, I guarantee you, 30 days before, not one would have, that it's undeniable that racism is a public health crisis. And we're here to say collectively that Black Lives Matter. I guarantee you, 30 days prior, they wouldn't say it. Not only that, today, 39 national healthcare organizations in 45 states and Washington, D.C. signed on to the same pledge. Not just signing on, but said, we commit to the following things. And in all of our organization, all of the people on this phone, ask your organizations to create a racial justice action committee to take on institutional racism. That happened, and we have one at Rush with a series of recommendations that we think get at the root cause of the self-perpetuating system. So just to say, agree that change can happen quickly, and this is a moment we have an opportunity to make these changes at all of our institutions.
Yes, I'm really glad actually that you said that, because one of my other questions is related to George Floyd and its impact on us as a community. But I do just want to address one thing before we do that, because we are getting close to cutting on time. What someone asked, you know, it seems like you guys are saying that capitalism is really what we should be focusing on. And I hear that too. And I just for those people who are healthcare providers, if there's just like two things that each of you want to say that you think that they could do within their respective communities to quote unquote help Black, Indigenous, people of color, just because we want to give people some sort of action item. I hear what you said before about talking to their organizations that they work for, but is there anything that they can do interpersonally besides being consciously aware? Because I think it's still hard for people to really understand what they can do, if that makes any sense. We're still getting questions about that.
Yeah, I'm gonna start and be brief and leave time for David. It's really important to recognize yourself and your sphere of influence. No matter where you are, whether you're teaching, you're a nurse, you're learning, you can be a voice. You can speak up in a meeting and find an opportunity to take action. You don't need to wait and look for someone else to help you. And you can read if you don't understand, and find those allies to collaborate with to take action. We give a lot of lip service to racial justice, and some of us aren't taking any action and actually changing anything. We're still living in a comfortable bubble. So as you think about taking action within your sphere of influence, there are opportunities right there. There may be comments, situations that you sit silent and watch. And if you really want to take action, you can do it tomorrow. What meetings are you going to? Share this work. There are many, many things that we can do if we're willing to take a risk. David?
Yeah, what I would say, maybe a few levels of the nature of work, and I think sphere of influence important. Number one is learn how to speak about it, learn how to see it, make what's been invisible visible. It's a lot more visible in the last, since COVID and George Floyd and the other murders, and it's a lot more vivid, but learn to speak about it in different places. And even if you feel uncomfortable, find ways to speak about it, because this is about having conversations with other human beings in the moment or after the moment, and not just on social media. I mean, really talking to people
Right.
about it. So speech is important, number one. Two is, for all of you who are patient-facing, there's always going to be an opportunity through personal advocacies around issues that have giant implications, either at the organizational level, at the community level, at the regional level. And so learning how to be an advocate for that patient, a group of patients in front of you, or the community. Three, get involved with community organizations if you have time or experience to it. There's a famous phrase from the disability community about nothing about us without us. We're not here to be Joan of Arcs or things like that. We're here actually to follow the lead of what the community wants and needs. And that means you have to, one can be involved with any sorts of community organizations that's doing this kind of justice work, from national political organizations, Physicians for a National Health Program, to local communities that are advocating around their health. And then we can be voices of change within our institutions. Our medical students and our nursing students have been powerful voices. And when they critiqued our statements, we thought we had pretty good statements, but they were right. So don't minimize the power you have. First of all, you're paying for your education, for God's sakes. Everyone else is making money and you're paying for it. Your voices within your own organization. So that's it. And that's what I would say. There's a lot that people can do that's material. This is not theoretical work.
Great. So I'll just ask this last question. Just shifting the focus a little bit, just talking about the George Floyd murder that occurred in May. 67% of adults polled in June said that they support Black Lives Matter movement. But this month, there's been a notable decline in support. Now 55% of adults support the Black Lives Matter movement. The trend is different when we look at race. 87% of Black adults support the Black Lives Matter movement, which is actually an increase by 1% since June. 45% of white adults said that they strongly or somewhat support the Black Lives Matter movement, which is down from 60% of adults who expressed the same sentiments in June when we all watched the murder, or as you mentioned, David, the lynching of George Floyd. Among Latinx adults, support dropped from 77% to 66%. So is the Black Lives Matter movement a trend? And why is it important for everyone, not just Black people, to support the movement? How do we all benefit, and what should we be doing? Lena, I'm going to ask you first.
I think what I like to call this time being heralded by the Black Lives Matter movement is our racial justice revolution for your generation. And there have been incredible changes in our culture, our mindset, and our values during this time. So it's way more than a trend. We are inundated with media headlines, and this time, this lockdown, this COVID has allowed us to think for ourselves, having a moment where we're not being exploited by our jobs or employment. Everything is in question. And so we can really galvanize and use and work with the movement to transform the culture in the way that we want. I like us to think in innovative ways and not be predictable or have the expectations, or that some TV pundit knows what our future is going to rely on. And part of racism is it takes away your humanity and the idea of human potential. And our work with Proviso Partners for Health starts there. So when I meet with a community, I don't want to look at the problems that they have. I want to know about their hopes and their dreams and their possibilities. And no pundit on TV and no statistics is going to tell me what my future is going to look like. I'm going to create that future. And Black Lives Matter is a part of that. And what I do locally and what I do nationally is going to be a part of that. So I'd like to throw those numbers in the can and really work with people like we are tonight to touch their lives and inspire them to make change where they are. There's a lot of hope within the Black community that gets ignored, and a lot of resilience. And we're so quick to talk about what's not working, and we don't spend enough time looking at the actual solutions that are happening. David?
Yeah, I would agree. I wouldn't, I don't take the numbers that seriously. I also remind people, for marriage equality, you never get to 100% before something happens. It's about 50%. If we can, I think the idea that we're in a fluid place in this country, and in this fluidity, there's great opportunity. These kind of dialogue, the session that you've organized, Jessica, having these voices, getting us around a table and having dialogue, getting to deeper understanding, talking about assets versus deficits, resilience versus gaps for people, or I just think that I wouldn't hang my hat on any number. It's critical that we move along. And let's end on this note. Matters is a low threshold.
Right. Power
Is what it's about. Because when you have power, and this is at the community level too, at the community, if you have power, with the political power, economic power, you can control and manage your destiny. And I say, equity is all about who has access to power, resources, and money. I want to encourage everybody to get out and vote. how the direction of this country has to do with how we shape political and economic decisions that affect, as we mentioned, broad swaths of this population. And I'd focus less on a poll in a given point in time.
I think that's good, because a lot of times, again, we're very, unconsciously controlled by the media and the news. And so it's really important to hear that these statistics do not have to dictate our future. And I agree with you, power is something that we should be striving for. And the way in which we do that is addressing policies. And I hope that was clear to everyone, that individually you can address policies on a national level by voting, but you can also address the policies within your own neighborhood. And Mercy Hospital is a wonderful way to start doing that for the people who are in Chicago, because Mercy Hospital is going to close, and it's going to limit access to care for people who live on the south side of Chicago. And that is an example of systemic racism. And so who is in charge with that? It's the governor. Call the governor, get on the phone with the governor, go out and rally and support that hospital and show that you actually care about the people who live on the south side. That's another way in which you can get involved. And if you have any questions, feel free to email us at whitecoatsforblacklives.stritch@gmail.gov, and we can provide you with more ways that you can be involved in the work that's already going on with that. And in the respect of time, there's so many things that we could talk about. And fortunately, we have another session. This is a 4-part series. And so this is just the beginning, although I would love to continue to have conversations with David and Lena, because both of them have so much experience, and Lena really knows how to get you in touch with your heart and your soul. And so I just want to thank both of you, Dr. Hatchett and Dr. Ansell, for taking the time to be with us today. And I also want to encourage everyone to please, join us at our next session, which is October 6th. And we will be discussing, I will actually be one of the panelists this time. I will be speaking with Dr. Brian Williams. We're going to be discussing systemic racism in the United healthcare system and United States healthcare system. And I think a lot of the questions that you guys have already asked us, we will probably answer those that we were not able to get to at this session. So that's something to look forward to. Again, that's October 6th, 7 p.m. Central, and systemic racism in the United States healthcare system. Again, thank you to Ministry, who helped us a lot with facilitating the logistics. And thank you to all of you who decided to attend. We hope that you enjoyed the conversation.
Thanks so much for this
opportunity
and your leadership from the entire team, Jessica, Michael, and Ministry.
Yes. Second that. Thanks, everybody. It's terrific. Michael, Jessica, Dr. Hatchett, it was wonderful to be on this panel with you.
Yeah.